Good morning, I'm Jessica Lovell. Today we bring you an encore presentation of one of our very favorite programs. We'll still be live with you this summer, Monday, Wednesdays, and Fridays, and then come September, we'll be back with our regularly scheduled programming. Until then, enjoy this encore presentation and make it a great day.
Good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. I want everybody to stop and take a deep breath. First, I want you to blow all the air in your lungs all the way out. Take a slow, deep breath all the way in. With that breath, and with every other breath we take, oxygen rushes into the lungs, and when we exhale, carbon dioxide runs out of our lungs. When we take that deep breath in, the oxygen moves into our bloodstream. Now imagine taking a deep breath, filling your lungs with oxygen, only the oxygen can't get into the blood. That is the reality of people living with Stites or I.L.D. This is a group of diseases where inflammation and or scar tissue blocks the all-important exchange of gases inside the lung. Today, we're hearing what it's like to live with the most common form of interstitial lung disease called IPF, or idiopathic pulmonary fibrosis. We'll show you what's happening inside the lungs of someone with IPF. It's deadly, it's incurable. But we'll also discuss how new drugs and research are helping patients breathe easier and live longer. Joining me today is Dr. Mark Hamblin, an outstanding pulmonologist and a good friend of mine who's the director of the health system's I.L.D. and Rare Lung Disease Clinic. He's not just treating patients with this disease, but also improving ways to improve detection and therapies. Good morning. We're happy to have you all here today. In a few minutes, we'll be talking to one of his patients, Madonna Mergenmeyer, who will share her experience with IPF. Let's start with a quick anatomy lesson. Inside your lungs, you have tiny air sacs. They are at the end of all your little airways that go all the way out, and you see that whole group that looks like a cluster? It looks like a cluster of grapes. Each one of those little grapes is an alveoli, and you see the little kind of net over those grapes? Well, that net, imagine that as the bloodstream, both the arteries and the veins, the capillaries, and that's where exchange between the oxygen and the carbon dioxide takes place. Oxygen comes in, carbon dioxide goes out, right there at those little capillaries and those little alveoli. But with IPF, or idiopathic pulmonary fibrosis, scar tissue grows in between the alveoli and the capillaries, as demonstrated in this illustration. Scar tissue makes it harder for the blood to get the carbon dioxide out and to pull the oxygen in, because it's got to go across that scar tissue. More scarring means less and less oxygen in the bloodstream. And it means one other thing. It's so easy to breathe unless your lungs have a lot of scar tissue, and then they're really stiff. And that makes it really difficult to take that deep breath that we get to do so easily. So Dr. Hamblin, what's up with this scar tissue? How does IPF scar our lungs?
So basically, it turns out that it's really kind of a genetic disease, and it really takes into account a lifetime of different exposures that might trigger fibrosis in somebody who's genetically susceptible. And so when you look at all the different possible exposures that you could accumulate in your lifetime, it's usually things that revolve around air quality. And so this could be smoking, it could be welding, or even just poor air quality issues, people that are exposed to a lot of agricultural dust. But if they're genetically susceptible, over time what happens is you get fibroblasts, which are scar cells that move in and begin to take over the lungs. And the more fibroblasts that come in, the stiffer and more scarred the lungs get.
It does. That makes it really hard to breathe. And I didn't do such a bad job explaining that for an old guy.
No, you did well. It seems like you were a pulmonologist.
Yeah, once upon a time, I guess. So the I of IPF stands for idiopathic, meaning we can't pinpoint a cause. That's in medicine when we like to still sound like we know something. We don't. We call it something like, it's not called, we don't know pulmonary, it's called idiopathic. Makes us feel better.
Right.
But do we have any clues as to what might be causing this disease, or what's triggering that pulmonary fibrosis to go?
Well, I think, back in the, 1950s and 60s when it was first getting named, we really didn't know what was going on. But now, over the last couple of years, we've really started to uncover a lot of the genetic reasons for why it develops. And we do know that it can be any type of environmental exposure that triggers it in a genetically susceptible individual.
So really, you're giving me an excuse to fly fish on the mountains all the time.
Yeah, absolutely.
Excellent, good plan. So IPF is deadly. You brought a graph showing that it's deadlier than many cancers.
Yeah, in fact, it kills just as many people each year as breast cancer, and yet most people who get diagnosed have never heard of it, and their families have never heard of it.
Wow, that's amazing to think about it killing more people than breast cancer every year. Does it feel like there's more patients with IPF than ever?
Yeah, and I think that part of that is because we're doing a better job of detecting the disease.
Yeah.
And so more and more people are getting diagnosed that maybe weren't getting diagnosed before.
So, and it gets worse, it's progressive over time. So talk to us a little bit about what that time frame looks like.
So it's an interesting disease in that it's really hard for patients to sometimes tell that they have it. Because in the beginning stage of the disease, there are microinjuries that are happening, the fibrosis is beginning to take shape in the lungs, and yet most people are asymptomatic. But as it progresses, people do start noticing that they're getting a little bit winded, but it's such an insidious progression that people notice that they're a little bit winded on stairs and inclines, and they think, I'm just getting older, I'm just getting out of shape. Maybe they start developing a cough. When they finally realize maybe this is actually a real problem, they go to the doctor. Doctors often thinking, you're a smoker, maybe this is just COPD. They try a lot of different therapies. And a lot of times it takes people almost a year and a half to get diagnosed. They might be misdiagnosed at least 3 times. And, in the last few years, we've seen some data where almost half of people are oxygen dependent by the time they get diagnosed.
Ouch. That's a long time before you get diagnosed. Yes. It is sort of, like you said, insidious is that great word because it feels so sinister. Let's take a look at some chest CAT scans. Here's what the lungs look like as the disease progresses. Walk us through some of these things.
So this is a patient where we're seeing an image around the time they were getting diagnosed and then 3 years later. And right here, we're at the bottom portions of the lung. This is the diaphragm, heart here. So this is bottom of the right lung, bottom of the right lung, or bottom of the left lung over here. Up in this area is kind of what normal lung tissue looks like. Down here, you can see some early scarring, which is these white lines coming in from the edge. But you can see that over the next 3 years, it's just progressing, and you're just replacing that lung tissue with scar.
I know people talk about that as honeycombing, and it does look like honeycombing, right?
Yeah,
and,
looks like a beehive.
Yeah, and you can imagine how much stiffer that is. Because part of the problem is people just get tired breathing.
Yes. It's something where you really can't expand the lungs, and sometimes people feel short of breath even when their oxygen levels are fine just because the lungs won't expand like they want to.
And you can be short of breath even at rest.
Yes.
And that's when you know the disease is really severe, and you like to try and intervene a little bit earlier than that. Well, that's tough, and currently there's no cure for IPF. Now, we have another pair of CT scans. We can see a huge change on the right, and that looks like a brand new lung. What happened here?
And so this is somebody who has undergone a single lung transplant, which, sometimes people get a single lung, sometimes they'll get a double lung. But right now, the only treatment that we have that truly reverses the disease is lung transplant. But you can definitely tell with this new transplanted lung how much healthier that looks. There is no scar tissue there. Compare it to their native lung on the left, and you can see over time that what was just mild fibrosis, there's really no lung left. It's just scarred down, and you can even see that it's literally a third of the size that it was before, showing that restriction.
It's pulled the whole mediastinum over this direction because it retracts, and that scarring process, we forget. Well, we don't forget, we see it, but it's really powerful, and it makes the lung really, really, really stiff. And like I said, that new lung looks great. And as a fan of lung transplant, I love to see that. All right, but not everyone can get a lung transplant. So then that's a challenge, because people with underlying disease, or they've had some cancers or heart disease, it makes it very difficult. Trying to constantly find new drugs, and clearly we'd like to slow the progression of the disease. Now, there are a few that are starting to come out that have been able to show some benefit. Talk to us about those drugs and what kind of difference are they making?
So the way we treat this disease right now is with antifibrotic drugs. And in 2015, the first 2 antifibrotic drugs were approved, pirfenidone, or Esbriet is its trade name, and nintedanib, or Ofev, which is its trade name. And these drugs both end up being pretty equally effective. They slow the progression by about 50%. So whatever progression you might have over 1 year, over 2 years. But they're most effective earlier in the disease. A lot of times if we're getting to a diagnosis late and getting those drugs started late, they're not able to do as much.
So what's the average survival after diagnosis?
So historically, we would say that the average survival is about 27 months.
Ouch, that is tough, right?
Yes.
Really tough.
It is. Now, we do know that there can be some differences with the genetics, and so some people might actually live longer, but some people might actually live shorter. So it really does matter what we're dealing with.
Yeah, that's really tough. All right, well, we have a patient that's here with us today, and so we're going to talk with her about what it's like living with IPF. Madonna Mergenmeyer was diagnosed in 2019. Donna, welcome to our program. Thank you for being here this morning. So you told us the diagnosis came while you were getting checked out for sleep apnea. Talk to us about how all that happened.
Well, actually, I was already diagnosed with sleep apnea, and I had just went on Medicare, so I needed to have a face-to-face with my doctor here in Topeka. So I made the appointment, and the nurse practitioner I normally see wasn't available, so there was a visiting doctor, and we were just talking, and I told him about my brother, who had a double lung transplant and had IPF. And so anyway, he listened to my lungs and he said, well, I'm going to send you for an x-ray and then possibly CT scan. And so when he said all of that, I mean, I did follow up with it, but I thought he was overreacting because I had no symptoms. And so anyway, I had the x-ray, and then they called me and they said we ordered a CT scan and said it was very important that you follow up with this. And I did, and then I was shocked. I really couldn't believe that I was actually having, the same diagnosis. But anyway, I feel very fortunate because it was caught early.
Yeah, that is good. Now, do you ever have to stop and just focus on your breathing?
No. I mean, I play pickleball 3 to 4 times a week, and I mean, I can keep up with everybody else. And I play with some pretty good players.
Yeah,
so,
awesome.
So anyway, I mean, I just feel fortunate, and actually, in March of the year I was diagnosed, I had viral pneumonia, and I was hospitalized. I was very sick from that, and I completely recovered from that. That's why I thought this doctor was overreacting when he listened to my lungs. But fortunately, he followed through with what needed to be done, and I was immediately put on OFEV, and I told them I wanted to see Dr. Hamlin, and the rest is history.
And how long ago were you diagnosed?
In 2008, it was like late July 2019.
That's awesome. So this is a successful.
And I think I saw Dr. Hamlin in November of that year.
Oh, that's awesome. So talk to us a little bit about what this.
Yeah, so this is, obviously one of our great success stories. This is, the power of getting the disease detected early. When Madonna got diagnosed, I think her lung function was still close to 100%, and probably only about 5% of the lung was affected by the fibrosis. It was very clear that that's what it was, and obviously I had taken care of her brother, and he had more advanced disease and came to us late, and at that point all we could do for him was get him a lung transplant. But for Madonna, she is showing the power of these antifibrotics if you start them early. She's really had very minimal decline over the last 4 years almost.
Well, that is awesome, especially if she's a champ pickleball player, which is what I hear.
Yeah,
So that's pretty darn good. So,
I wouldn't say I was a champ.
now,
Don't let her lie to you. She's good.
She's good. How's your brother doing, Madonna?
He's doing very well. He's about 6 years out now, and it's not easy. He takes a lot of medication, but he follows exactly what the doctors tell him to do, and he's doing quite well. And fortunately, he was able to see Dr. Hamlin, who diagnosed him, because he was misdiagnosed for years. And Dr. Hamlin, I feel, is who saved his life.
Yeah, that's an awesome one. Congratulations.
Yeah.
That's a great care. And so this genetic component, that kind of feels like what must be acting here with both she and her brother.
Yeah, in this case it is. And we know that probably at least 20 to 30% of the time it's familial, but we suspect that even the sporadic cases, we know it's genetic, and we probably figure out that there's somebody in the family that had it, and they probably just misdiagnosed with COPD or something else. And I think we'll see more and more cases where the familial count starts to rise.
So Maggie, the pirfenidone has worked remarkably well. How often do you see that profound of an improvement, or not even, but just like stability?
So if we get it started very early in the disease, it works incredibly well because it is slowing the progression by about 50%. And early in the disease, you may only be losing, 40, 50 milliliters of lung function per year. But every 10% drop in lung function, it doubles in terms of how quickly it's progressing. And so in her brother's case, he came to me very late. And if we would have done the antifibrotics, they would have had marginal effect. And so he really needed a lung transplant. But for Madonna, we got to her when maybe only 5% of the lung was scarred. And so the drugs have worked incredibly well. And 4 years later, she's still doing great.
And we've talked a little bit before about side effects from this, but Madonna, are you tolerating pirfenidone well?
OFEV.
Yes, I really do. I mean,
Yeah.
Yeah, OFEV. Yeah, it's my symptoms have been very easily managed, and yeah, I tolerate it just fine. So
That's awesome. Hey, one other couple of questions I think we might want to take up. Some people are confused. I talk a little bit about cystic fibrosis. You talk about pulmonary fibrosis. Let's talk about that difference for just a minute.
So they've just got that one word, fibrosis, in there, but otherwise they're
messy. Yeah.
almost very different diseases.
Yeah, it really is. Cystic fibrosis is really a disease of too much thickened mucus as a result of the inability of the body to exchange salt and water correctly in the lung and other organs as well. It's really a systemic disease. Pulmonary fibrosis, though, is more about scarring.
Yeah, it's basically you have fibroblasts, which are the scar tissues, which are just overtaking the lungs. Probably the only similarity there is, there's a few genetic mutations where patients do have some mucus hypersecretion issues, but it's completely different than the way it is in cystic fibrosis.
Yeah, and the other thing is, you and I both take care of a lot of lung transplant patients. Mm-hmm. You have to make sure you talk to people early on about having a lung transplant so they can get ready for it. There's a little bit of a wait for a lung transplant too, so it's not something you can just go get.
Yeah, well, I think it depends on the region that you're in. And so we know that there are different organ sharing network regions. And as it turns out, for my pulmonary fibrosis patients, which probably different than for somebody who has COPD, that at least in our general region, which we send a lot of our patients to St. Louis for transplant, there the average wait time for a lung transplant for pulmonary fibrosis is only about 30 days.
So which is really pretty remarkable because years ago it was more like a year, and in a disease which can progress rapidly like pulmonary fibrosis, a lot of times people are dying on that waiting list.
Yeah, and so I think they updated some of their guidelines for who gets a transplant, prioritizing those fibrosis patients.
Yep, good thing. All right, well, this has been a great discussion today, and I'm grateful to all of our guests for being here. I want to hear final thoughts before we go. Madonna, first of all, congratulations on your pickleball game. Congratulations on your response to the therapy. What final thoughts would you like to leave us with?
Well, actually, what I'd like to say, if you have been diagnosed with IPF, don't hesitate to take the medication. I have heard in some instances where people are a little hesitant. And also, too, if your physician does not immediately order OFEV, you might want to seek a second opinion, because I've also heard of that happening. So I would just say take the medications. If you are lucky enough to participate in a clinical trial and qualify, do that as well. Dr. Hamlin and his team, they're all wonderful. And I think the research is so important. And lastly, just stay active physically, socially. I just feel that is so important as well.
Yeah, I totally agree. Dr. Hamlin, again, thank you for being on the program. Thanks for developing our Pulmonary Fibrosis Interstitial Lung Disease Center and program. Final thoughts?
Well, one of the reasons I'd wanted to bring Madonna on too is because she's actually participated in a lot of clinical trials. And we know that the drugs we have right now, they're just not good enough. And so we're working hard to help develop new therapies. We probably have about 10 novel antifibrotic drugs currently going through clinical trials available here at KU. Madonna's been involved in a couple of these trials, and we're starting to see that not only are we developing better therapies, better tolerated therapies, we may actually be getting some therapies that begin truly changing the course of the disease, maybe even reversing some of the scarring process.
I love that term, reversing disease. That is the most amazing thing. So congratulations, good luck on that. And folks, remember, we always talk about faith, hope, and science, and how that's a powerful combination.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.